but it's taking a really long time to grow back.
So if it starts climbing again?
Then you would have to make a change. Then you would have to make a change. Because, you know, it's okay, if you know, I wouldn't, if somebody's in a lot of pain, if they're anemic, then stable isn't good enough, because they're feeling badly, so stable feeling badly is not good enough. But if the disease improved, and there's still some left, but it's sitting there and it's not growing, that is not a reason to change. In all the studies we have, and that other people do, you're not eligible for the study with a new drug if you're stable. Why? Because nobody thinks it would be the right thing to do. Now the harder thing is sometimes these drugs make people not feel so good. So you get into this, do you take a chance by, say, stopping the drug or trying something else when the treatment has knocked it down to a low level? And that's where you know, I wish I had a better crystal ball, but that's really what it comes down to. You're kind of weighing well, what are our options? You know, how bad would it be if we stopped and it grew back? But if you feel fine and it's stable, it can be that way forever. I've seen it that way for 15 years in some people. They've never been in remission. So Revlimid, or lenalidomide, was tried more recently, mainly because Revlimid, for the average person, is a little better tolerated, but again, not for everyone. And so they compared after one transplant, which is kind of more common what we've done now. Half the people took Revlimid, half the people took the placebo. And these people are staying in remission twice as long compared to those. But there's still some people here that are in remission. And then the survival is a little better for these people than those, but not dramatically. But it hasn't been a lot of time yet to know for sure.
Did you just mention that they're just doing one transplant instead of a tandem now?
Most of the time,
Really?
most places. You know, there's the studies from 10 years ago, the 2 transplants were, if you took 100 people, treated these 100 people with 2 transplants, these 100 people with 1, and you looked 6 years later, the people that had 2 did a little better than the people that had 1. But the people that were in remission after the first transplant and had a second one didn't do any better than the people that only had 1. So if the treatment knocked the myeloma down to 90% or better, then there was no difference by doing a second transplant. But that's another area. People, you know, when you're talking about doing a transplant, it's been 2 months after the transplant, you go, oh, maybe we should do another one. Not many people jump up and volunteer at that. So, you know, generally what we do, I think most places, it differs though. Dr. Barlaghi is more aggressive and he keeps people, he does 2 transplants routinely. And in France, they do 2 transplants routinely. I'll usually personally just do 1 and collect cells and then, you know, have some for the future in case to do it again. And one advantage to that is then you can, when you look backwards, you can sometimes tell how well the transplant worked or didn't work. So then you know if doing it again, you know, would be reasonable or not. Now here's why I show the time to progression is better with in the light blue with the Revlimid than with the placebo. It's just kind of if you kind of throw everything at it. So in Italy, this is what they did. They gave Velcade and Doxil and steroids. Then they did 2 half-dose transplants. So it's kind of what's been shown equal to 1. So if you give half the chemotherapy, you tolerate it better, but you got to do it twice. So I don't know which way is better. We usually just do 1. And then they put people on Revlimid and prednisone. And by doing that, by the time you go through all those 3 things, 73% of people are in remission. So if you throw your best weapons at it, you know, 3/4 of the people get to remission. Now whether, you know, I think that makes it's better to do it that way. But the reality is, then, you know, the obvious question would then be, well, what if it comes back after you've done all this stuff? Then what are you going to do? And that's a valid point. But I think, you know, you worry about that later, and hopefully there are people where, you know, it's been 5, 8, 10 years and counting, and they're still in remission.
Excuse me. You talked about after the stem cell, they put it back in. But I also, at UCLA, they're talking about freezing it for 5 years.
So
Which one are they doing?
Well, if you're, some people say, I don't want to do that transplant, but you know, since my myeloma is good, doing well, why don't you collect it and just save it for a rainy day? Because maybe if the myeloma comes back, maybe I can't collect my healthy seeds. So some people do that. So that's kind of saving, banking for the future, basically. The way, you know, the way it's done more commonly is you collect the cells and then use those stem cells later. But when you collect the cells, you try to collect extra. So you collect cells to use for the transplant, but then you have some extra ones to use, because let's say 8 years from now, you know, say somebody had the transplant and everything's fine, and 8 years from now the disease is creeping upward again. Well, you can go, well, you know, it wasn't so terrible to have that transplant. You know, maybe we do it again. Now I'm hoping in 8 years we've got, you know, drug Superman, whatever, and we won't need those transplants, because it is, you know, not the most pleasant thing to go through. But since I don't know what the future holds, so they save them for the future, basically, if they collect enough. Trials, there's 3 parts to clinical trials. The first one is called a phase 1. So that's when a brand new drug, and they don't, you know, there's reasons to test it. I mean, these things are expensive to do for the drug company that's making these medicines. So there's reasons to believe that this medicine might work. So, but it worked in an animal, it worked in a culture plate. But when you first give it to a person, you don't know what's going to happen. So, yeah.
Excuse me, you had a question, go ahead.
It's going back to the transplants.
Okay, yeah.
What makes a person not a candidate for a stem cell transplant?
Mostly what makes you not a candidate is the age. So somewhat arbitrarily, when people are in their 70s, it's kind of getting to a maximum amount. People, you know, I've transplanted, the oldest person I've transplanted is 76. So I mean, but it's just your, you know, other clinical conditions. So somebody comes in a wheelchair and they're really weak and they've got emphysema, I'm not going to do a transplant on them because they got enough problem. They're riskier to go through something like that. So the first thing is that you have to be otherwise relatively healthy. And then you have to have the disease controlled well enough to be able to do it. And you have to have kind of healthy bone marrow. So sometimes I'll see somebody who said, you know, and it's easy in retrospect. It's easy like to say, oh, I should have turned left instead of right, when you turn right and there's a traffic jam. So some people, they come and they'll say, after years of treatment, uh-oh, you know, things aren't working, I want to do the transplant now. Well, their platelet count is 40, their white blood count's 2. I can't collect the cells. So they're kind of stuck. So you have to have a healthy bone marrow to do it as well. And then there's some judgment. Dr. Barley in Arkansas transplants 80-year-olds all the time. So it depends on where you are. So phase 1 is where you have a promising drug, but you don't know how much to give. So you start at a low dose. You don't start at, you know, you kind of give a little tiny bit that you're pretty sure is going to be safe, and make sure people tolerate it. And then after, usually it is, they put pictures of 3 people, usually it's 3 people. And they do fine, they don't have any side effects. You're just looking mostly for side effects. Then you try again with a higher dose, and you test 3 more people. And then you go up and up until you get to where you want it to be, or until somebody starts having side effects. And they, let's say they had terrible diarrhea. Like that might have been what happened with Velcade as an example. I think it was what happened with Velcade. So they go, whoa, that's got, that's too much. We got to back it down a notch. And then that's the dose. So then once you know the dose, then you do the phase 2 trial. Like, okay, now that we know it's 1.3 milligrams per meter squared of Velcade 4 times every 3 weeks, then we test it to see, okay, if we take 100 people with multiple myeloma, how often does it work? And that's a phase 2 trial. And then a phase 3 trial is where usually you compare it to something else. So you would, which is surprising, was never done, but Kyprolis compared to Velcade. I would like that study to be done, but it was never really done because Kyprolis got approved just based on this. They never had to do a comparison to Velcade. And Revlimid got approved based just on this. They never had to do it really in comparison to something. Well, they compared it to dexamethasone. That's not true. They compared it to dexamethasone by itself, actually. The steroids. So that just kind of tells you, if you're thinking about a trial, kind of where things are. These are, we're kind of figuring out how to use it, but it looks promising. Here we know how to use it. How well does it work? And then here it's, okay, there has to be some promise to go into a phase 3 trial. Because these usually are big studies, like hundreds of people. So you wouldn't, if it didn't work in anybody over here, you're not going to do some big, huge trial over here. So let me just talk a little bit about the new drugs, and then we'll stop and maybe have the lunch, I guess, and then I'll answer questions after. So the new drugs that just came out in the past year and a half, Kyprolis. So Kyprolis is like bortezomib, like Velcade. Every these drugs have 2 names. I don't know how it comes up with those names, but that's what it comes up with. This one's given differently. So Velcade is given, as an example, Monday and Thursday, and then you take a week off. And eventually people take it once a week, because it's more convenient. This Kyprolis is 2 days in a row. So not Monday, Thursday, but Monday, Tuesday, and you do it 3 weeks out of every 4. So there's a lot of visits to your local doctor. It seems to be similar in efficacy to bortezomib, but they never did a phase 3 trial. So for some people it seems to work better. For other people, I've seen Velcade work better than Kyprolis, actually. What it does have as a definite benefit is it's much less hard on the nerves. So it doesn't seem to damage the nerves nearly as much. It can a little, but it's not nearly as bad as bortezomib. So it's more cumbersome to give because you have to do it in a vein. And I'd rather have a shot than have a nurse try to find a vein on me all the time. And it's also kind of inconvenient. That's the downside to it. In order to get it, at the moment, the only way insurance companies will pay for it is that you have to have had Velcade and an IMiD, which means either Revlimid or Thalomid. So thalidomide or Revlimid, you have to have had both of those before you can get this drug. Otherwise, more and more insurances, they have this, like somebody in Omaha is like checking boxes, and they got 4 boxes to check, and if you don't have all those 4 boxes checked, then you get denied. That's kind of how it works nowadays. Once in a while, you can get on your knees and beg and get nasty, but usually they don't succumb to that, unfortunately. So just to show you, this is a study giving it with Revlimid and dexamethasone. This isn't the way I would say most people usually give it nowadays, but you know, you're given 3 drugs that all work pretty well. These are untreated patients. So here's Revlimid you give every day as a pill. Dexamethasone you do it, you know, 1 day a week. And then the carfilzomib's twice a week. And pretty good. There's not that many patients, but basically it worked in everyone. Didn't put everybody in remission, but it put a lot in remission. So it's a pretty effective regimen. We're actually trying it with Cytoxin in newly diagnosed patients with multiple myeloma. So, and we're trying to see if we can give a higher dose, and we have been able to. So it's the normal dose is 27 milligrams per meter squared eventually. So we went to 36, and then 45, and then 56 actually. So 56 is the dose we're on. So it's really double the dose that you usually give. And so far, everybody's gone in remission that we've given it, or three-quarters of people got in remission so far. So these are, you know, you start combining things right now. Usually, if you were to get carfilzomib, most of the time people would just give it with the steroid, without the third drug, because that's how it was approved. So then the next drug that came along is called pomalidomide. So if you look at the thalidomide, it's got that oxygen. You look at the lenalidomide, it's got that nitrogen group. Now pomalidomide, put them both together. None of this, I mean, not that I could make the thing, but you know, some of these things when people come up with new kinds, it's relatively intuitive, like what you might want to try to do. So Celgene, when they first got this compound, they just had some chemists just make all kinds of variations, and then they would test it in culture plates and see, oh, this one works well, this one doesn't, and then that's how they came up with this. And it works. It doesn't work in everyone. This was a study from, I think this is from France, where they gave it like thalidomide, where you give it every day, because thalidomide you do every night. It's a sleep, kind of makes you sleepy, so normally people take it at night. Whereas Revlimid, you have to take a week off to let your bone marrow have a chance to recover from Revlimid. So when pomalidomide came out, it's kind of got, it's like features of thalidomide, features of Revlimid. How do you use it? Well, they tried both. They saw which way was better. Oh, I said it wrong. So this is the way, 3 weeks on, 1 week off. Arm eggs, days 1 through 21. And the responses were basically the same, certainly weren't worse. And the side effects were about the same, maybe a little bit better. And, you know, it's 7 less pills to take, and at, you know, $10,000 for a month of pills, that was an advantage. Take 7 less. So this is the way it's given, the 3 weeks on, 1 week off. There's another drug it's actually approved to treat lymphoma and this chronic lymphocytic leukemia, which is kind of like myeloma. It's called bendamustine, and it's a chemotherapy drug. It's similar to the melphalan and cyclophosphamide. So it's related drug. It was developed in East Germany, and so that's why, you know, it's actually was made 30, 40 years ago. I don't know, 30 or 40 years ago, but nobody really heard much about it because it was made in East Germany, and you know, they didn't get across the wall, I guess. So it's actually now when people have lymphoma, and as I kind of alluded to earlier, lymphoma cancers or cancers of lymphocytes. Well, plasma cells are lymphocytes that have matured. So cancer of plasma cells, cancer of lymphocytes, a lot of similarities there. So a lot of drugs that work for multiple myeloma work for lymphoma and vice versa. So bendamustine is now the main drug used to treat lymphoma. So it's been used to treat multiple myeloma because it's not probably going to ever be approved to treat multiple myeloma because it went off patent. And so the company doesn't want to bother doing studies with it. But it seems to work, so you give it intravenously. There's different ways of doing it. This is one way of doing it with Velcade. You can do it without Velcade. The way it's treated with lymphoma, they don't use Velcade. They give a higher dose of the bendamustine 2 days in a row with the dexamethasone.
Is that why they're trying like Verinostat and some of the other ones that were approved for lymphoma on
Exactly.
multiple myeloma?
Exactly. And it turns out Revlimid, which was approved for myeloma, just became approved a few months ago for a type of lymphoma. You know, Velcade and Kyprolis are kind of cumbersome to use. I only got a couple more slides.
Okay.
Cumbersome to use because they're shots and IVs. So there is a pill that works on the same thing in the cell, the proteasome. So hopefully will work just as well. And so this one was given with Revlimid and dexamethasone in patients with multiple myeloma. And it looked good. 90% of people responded. And they're doing more studies with this drug. I don't know when it's going to be available. Probably will be at some point. But certainly would make things a lot easier. It's a pill. So especially like a maintenance type of treatment, it's a little easier to take a pill once a week than it is.
They also can charge $12,000 a month.
That's probably, and they probably, yeah, exactly. That's probably why they're developing it, yeah. And then the last drug I want to talk about is this one. It's called daratumumab. Yeah. So mab at the end means antibody, monoclonal antibody. Myeloma cells make antibodies. So what do antibodies do? They stick to things that you want your body to get rid of. That's why we make antibodies. If I have some bacteria floating around my bloodstream, hopefully my body will make antibodies to it, will coat the bacteria, and then my rest of my immune system says, whoa, that something came coated with antibodies, destroy whatever it is. So this is an antibody that they developed that will actually stick to the protein CD38 that we all have. But we all have that protein on our plasma cells. So basically it's an antibody that will stick to a protein on plasma cells. So what would happen? Well, then the immune system says, it's stuck on something, this cell here, that cell must be bad. Kill that cell. So it's a way of targeting myeloma cells and having your own body's immune system attack it. So in the phase 1 trial, so remember phase 1 is the beginning trial where you're just testing doses. Once they got up, now the first few people didn't work because they got a tiny, tiny dose. But once they got up to a dose they thought might be good enough, then 2 out of 3 people responded to it, just by itself. The only side effect is I'll get to you in a second. The only side effect is that when you give somebody a protein, a foreign protein, some people can be allergic to it because your body can see the drug as being foreign. So that was its main side effect. It didn't seem to have any other side effects. So we're hoping to have the study open in a couple of, 6 weeks or so at Cedars. Yes.
Could you explain how steroids help us?
Sure, but I'm going to show you. I'm going to go way back. I think that was my last slide, so I'm going to go way back. I'm sure there's a faster way of doing it, but this is the most reliable way.